Necrosis is a form of cell death that occurs as a result of exogenous injury. It is characterized by plasma membrane damage, leakage of intracellular components, enzymatic degradation, and protein denaturation. Unlike apoptosis, necrosis is accompanied by a local inflammatory reaction. There are several types of necrosis, each associated with specific causes and distinct histologic features. Coagulative necrosis is most often seen in ischemia or infarction affecting most tissues, with the exception of the brain. The ischemic or infarct-related injury denatures enzymes, which prevents proteolysis. Histologically, the cellular architecture is preserved so that cell outlines remain visible, but the nuclei disappear. Cytoplasmic proteins bind more strongly to eosin stain, leading to increased eosinophilia and giving the tissue a bright red or pink color. Liquefactive necrosis occurs in bacterial abscesses and in infarcts of the central nervous system. In this process, neutrophils release lysosomal enzymes that digest the tissue. Early in the course, microscopic examination reveals cellular debris and macrophages. At later stages, cystic spaces and cavitation appear, particularly in the central nervous system. In bacterial infections, neutrophils and cell debris are prominent histologic findings. Caseous necrosis is associated with tuberculosis, systemic fungal infections such as Histoplasma capsulatum, and also with nocardia. In this type of necrosis, macrophages wall off the infecting microorganism, leading to the formation of granular debris. Microscopically, fragmented cells and necrotic material are surrounded by lymphocytes and macrophages, forming granulomas. Grossly, the tissue has a soft, cheese-like appearance, which is the origin of the term caseous. Fat necrosis can be enzymatic or non-enzymatic. The enzymatic form is typically seen in acute pancreatitis, in which damaged pancreatic cells release lipase. Lipase breaks down triglycerides, and the liberated fatty acids bind calcium ions, resulting in saponification that produces a chalky white appearance in the peripancreatic tissue. The non-enzymatic form is usually traumatic, for example, following injury to breast tissue. Histologically, outlines of dead fat cells can be seen without peripheral nuclei, and areas of saponification combined with calcium appear dark blue on hematoxylin and eosin hand stain. Fibrinoid necrosis occurs in blood vessels and can result from immune-mediated vascular reactions, for example, polyarteritis nodosa, or from non-immune vascular injury, for example, hypertensive emergency or preeclampsia. The mechanism involves deposition of immune complexes, which is a type 3 hypersensitivity reaction, and or leakage of plasma proteins, such as fibrin from damaged vessels. Histologically, vessel walls appear with a brightly eosinophilic layer of proteinaceous material. Gangrenous necrosis is most often seen in the distal extremities and in the gastrointestinal tract after chronic ischemia. In dry gangrene, tissue death occurs from ischemia alone, and the morphology resembles coagulative necrosis. In wet gangrene, there is superimposed bacterial infection, which adds liquefactive necrosis on top of coagulative necrosis.